Thank you so much. Thank you for the opportunity to present here at SAGE's meeting. Okay, nothing to disclose at this moment. First, I'm gonna give you a background, a background of my country. Costa Rica is in Central America. We have 5 million population, only 300 general surgeons, and currently there are 35 general surgery residents. For all the healthcare in Costa Rica, it's provided by a government entity called Caja Costarricense del Seguro Social. So for easy, we will see CCSS. In Costa Rica, the healthcare is basically a public healthcare system, and everybody has right to have healthcare attention. The main program of general surgery residency is carried at national hospitals. We have 3 national hospitals, 7 regional hospitals, and other smaller hospitals and clinics to provide healthcare. Postgraduate education is ruled only by one institution, and only one university endorses or supports the title of a specialist in Costa Rica. Not going. Okay. Oh, thank you. There you go. And what about laparoscopic surgery in Costa Rica? Really, it's their widespread use of laparoscopic surgery in Costa Rica, and we perform from GLabs, appendectomies to more complex and advanced procedures. We do bariatrics, gastric, pancreas, colon surgery, and all are performed in public health hospitals and private hospitals. For 2018, CCSS reported more than 12,000 procedures performed in 29 institutions, and for 2019, around 13,000. For 2020, the number decreased because of pandemics. And what happened in Costa Rica, even when we have widespread use of laparoscopic surgery, what happened in the teaching and the learning of laparoscopic surgery basic skills? That we have no formal curriculum to teach them, no standardized education. It will depend where the resident works, the educators he or she has, and also the opportunity to assist to laparoscopic procedures, so it's not standardized. And since there is not an established program, also the evaluation of progress of the residents in their skills is not systematic and is more a subjective way of evaluation. We also have a lack of simulation labs, and even when we have them, their accessibility is not easy or is not as frequent as it should be. And even when we have good and great laparoscopic surgeons, few of them are trained to be educators, and they don't know how to teach basic laparoscopic skills in simulators, how to give adequate feedback, or to create good educational environments. So how did we overcome our limitations and discover our strength? That's because we had the opportunity to participate in GLab program for Go Global. We developed the program in one of the hospitals in San Jose, Calderón Guardia Hospital. And what did we accomplish when we joined together our hospital, our educators, and our residents with a GLab program? That we became better educators. We learned how to teach basic laparoscopic skills in simulators. We had another perspective. We trained the trainers, and we learned how to evaluate progress, how to give feedback, to debrief after working sessions, to find what we should do better next time, and to be more empathic with the residents and create a more healthy educational environment. Regarding the lack of simulation labs, we worked to create low-cost model simulators, so each resident has one, and we use them with the FLS supplies that GLab provide us. We also developed a program to make the evaluation at the beginning and at the end of the GLab. This is our team in Costa Rica, 3 general surgeons, 2 oncologists, myself, and 5 residents. It's really a small group of residents, but taking in account in Costa Rica we only have 35 residents. Doing a program with 5 residents is a nice number to start with. These are some of the simulators that we use through the program. We set the simulators in the offices of the Department of Oncology after working hours with patients. There we have our simulation lab in the offices where we work with patients. And after the sessions, we store them away and then we use them once a month during the program. For the low-cost simulators, we use plastic boxes, acrylic material, wood, paperboard boxes, and even when they don't look that nice, they were ergonomic, functional, and allow us to perform all the FLS tasks during the program. What about after GLab? We were inspired and want to inspire others at this time. We start working with the Costa Rican Society of Surgeons and work with another group of residents and educators in 3 hospitals this time, 1 regional and 2 national hospitals, 8 educators and 8 residents. We were working to share our knowledge. We have better tools to design a program for telementoring and telesimulation. We organize virtual lectures, telesimulation, and simulation on site. Sometimes the educators and the residents work in the hospital. And we also perform an evaluation at the beginning and at the end of the program after 3 to 4 weeks of deliberate practice. The lectures were in Zoom. All the people get to connect free, and we're around 1 hour to 1 hour and a half sessions about basic laparoscopy surgery, ergonomics, pneumoperitoneum, etc. For the telesimulation and the telementoring sessions, each resident has a low-cost simulator in the house that they can use through the program. We also have the same exercises and the same supplies, so the residents do the same task with the same materials, and it will work more standardized. The sessions were also by Zoom. Some of the sessions were in-site, simulation in-site, and the other group was by telesimulation. If we see, this is the result of a survey that the residents completed after ending GLab regarding the level of laparoscopic skills. They improve from basic to intermediate and higher if we compare beginning to the end of GLab. And if we transfer this in a very subjective way, 100% of the residents said that their performance in the OR was better, and also the educators feel and evaluate that the residents perform better in the OR after participating in GLab. When we compare the other group of residents, the one after GLab, the evaluation, this is just a graphic of a comparison in the time that the resident used to perform basic exercises, cut and circle, intracorporeal and extracorporeal knot. It shows that the time that they needed to perform the task decreased after practice and after telesimulation and telementoring. But after all these positive things, which are still our limitations? They are almost the same. We have to add COVID. COVID has changed the dynamics of the hospital and the dynamics of the residents. This year, the residency program was closed for a few months, and all the residents had to work in COVID wards. And also, the number of elective surgeries has decreased. Cost is always an issue. When you start working to create a simulation lab, you find cost is very important, and even when you try to do something low cost, you have to buy supplies, instruments, etc. But however, our biggest challenge was to change, or is to change, the mentality of most of educators and institutional authorities to believe in the importance of simulation in teaching basic laparoscopic skills and to reinforce the necessity of a formal curriculum to teach them. So what are the conclusions? We changed the way residents are trained. Probably this is still work in progress, but when we set the bar higher, then we know we are going to get somewhere better than we are now. We learn to become better educators, and this will impact the outcomes of minimal surgery in Costa Rica, and the benefit will be for the patients of our country. Thank you so much.